Today we are discussing on the topic of chelating agents. These are the drugs which complex metallic ion forming ring structures within their molecule. So in Greek, chel means crab. That means the compound holds the metal like a crab's claw. So these chelating agents, they are primarily used in heavy metal poisoning. So these compounds form stable, non-toxic and easily excreted complexes with toxic metals, and these are valuable in poisonings. The useful agents contain two or more reactive groups which are called ligands. Okay. So which can hold the metal from at least two sides so that a ring is formed. When the ring is 5 to 7 membered, it is most stable. So what is ligand exactly? Ligand, it is a functional group that is capable of forming coordinate bond. That is a covalent bond in which both the shared electrons are donated by the ligand. Generally, it is oxygen, nitrogen or sulfur atoms in the hydroxyl, carboxyl, keto, sulfhydryl, disulfide, amino or phosphate groups. So heavy metals, these exert their toxic effects by forming complexes with various biomolecules. For example, enzymes or other critical biomolecules. So chelating agents compete with body ligands for the heavy metal. They differ in their affinity for different metals. Clinically useful agents should have a higher affinity for the metal than for calcium, because calcium is readily available in plasma as well as in fluids. They also should have higher affinity than body ligands for the toxic metal. Moreover, to be effective in metal poisoning, their distribution in the body, it should correspond to that of the metal to be chelated, and they should be water soluble. So efficacy of all chelating agents in promoting excretion of the toxic metal and in reversing toxic manifestation. So this efficacy declines rapidly as the interval between entry of the metal in the body and the administration of chelator increases. So which chelating agents we have? Few examples include dimercaprol, also called as BAL, British anti-Lewicide, BAL. Dimercaptosuccinic acid, which is also called as succimer. Disodium aditate, calcium disodium aditate, calcium disodium DTPA, penicillamine, desferoxamine, deferripiron, and desferricirox. So coming to dimercaprol, British anti-Lewicide, BAL. This is an oily, pungent smelling, viscous liquid developed during the World War II as an antidote. So it was developed as an antidote to Lewicide. Lewicide is an arsenic containing war gas. So the two sulfhydryl groups of dimercaprol, they bind these metals which produce their toxicity by interacting with sulfhydryl containing enzymes in the body. That is arsenic, mercury, silver, nickel, Sb and copper. The complex of two molecules of dimercaprol with one metal ion is more stable than 1:1 complex. This is therefore desirable to maintain excess of dimercaprol in plasma to allow formation of 2:1 complex. The dimercaprol metal complex spontaneously dissociates, releasing the metal at a slow rate. Also, dimercaprol is partly oxidized in the body, further emphasizing the necessity to have excess dimercaprol available. But due to the dose-dependent toxicity of dimercaprol, large amount should not be given at a single time. So its dose includes 5 milligram per kg stat, followed by 2 to 3 milligram per kg every 4 to 8 hours for 2 days, then once a day for 10 days. So as stated earlier, the sooner we institute the chelating agent therapy, better it is. So when we give dimercaprol, we also need to alkalize the urine, because this complex, the dimercaprol metal complex, it dissociates faster in the acidic urine. Okay. Another use of dimercaprol is in lead poisoning as an adjuvant to calcium disodium acetate, also as an adjuvant to penicillamine in copper poisoning and Wilson disease. So in this, it is given in the dose of 300 milligram per day intramuscular for 10 days every second month. So it is partly oxidized and glucuronide conjugated, and it is excreted mainly in urine as such. In 4 to 6 hours. So this is in 4 to 6 hours. It is contraindicated in iron and cadmium poisoning because they form toxic product with dimercaprol. Side effects produced by dimercaprol, they are frequent, dose related, and they are also distressing. For example, rise in blood pressure, tachycardia, vomiting, tingling, burning sensation, inflammation of mucous membranes, sweating, cramps, headache, anxiety. So second is dimercaptosuccinic acid, which is also called as succimer. It is similar to chelating properties of dimercaprol, basically used in arsenic, mercury, and lead poisoning. Nausea, anorexia, and loose motions are the side effects. Another one is disodium acetate. It is a disodium salt of ethylene diamine tetraacetic acid. It is a potent chelator of calcium. It causes tetany on intravenous injection. But if we give it slowly, as a slow infusion, tetany does not occur because calcium is withdrawn from bones. So it can be used for emergency control of hypercalcemia in the dose of 50 milligram per kg IV infusion over 2 to 4 hours. But for this purpose, nowadays we prefer bisphosphonates. Calcium disodium acetate. It is the calcium chelate of sodium EDTA. Because this agent has higher affinity for lead, zinc, cadmium, manganese, copper. It can remove them from the body by exchanging with calcium held by it. Along with the toxic metal, some essential zinc may also be removed. It is highly ionized, therefore distributed only extracellularly. It is not absorbed from the gut, therefore parenteral administration is given. IV is preferred because intramuscular administration, it is painful. It does not enter brain or CSF. Therefore, it can remove toxic metals only from accessible sites. So it is excreted by glomerular filtration in urine. Half-life is 1 hour. So its most important indication is lead poisoning. For this purpose, 1 gram of its dose is diluted to 200 to 300 ml in normal saline or glucose solution and infused IV over 1 hour twice a day for 3 to 5 days. It may be repeated after 5 to 7 days. Also useful in iron, zinc, copper, manganese and other radioactive substance poisoning. It is not used for mercury poisoning. Its side effects include kidney damage. So proximal tubular necrosis, it is the most important problem. This problem is dose related and it may be due to toxic metal partly dissociating in urine. It can also cause acute febrile illness with the chills, body ache, malaise, tiredness in some individuals. Anaphylactoid reaction with fall in BP and congestion of eyes and nose is also reported. So this compound calcium disodium DTPA, its use is restricted and it has limited distribution in the body. Okay, so we are not discussing much about this compound here. Coming to penicillamine. Penicillamine, it is dimethylcysteine and it is obtained as a degradation product of penicillin. Penicillamine was found to have strong copper chelating property. In 1956, it was used for Wilson's disease. Wilson's disease is due to copper excess. It selectively chelates copper, mercury, lead, and zinc. The D isomer is used therapeutically because L isomer and the racemate produce optic neuritis and are more toxic. It is adequately absorbed after oral administration. Little metabolized in the body and excreted in urine and feces. When given to patients with heavy metal toxicity, excretion of the metal is enhanced. So its uses, one is Wilson's disease. Wilson's disease causes hepatolenticular degeneration. This is due to a genetic deficiency of ceruloplasmin. Okay. In this, which is ceruloplasmin, it is a protein which normally binds and disposes of copper from the body. So when ceruloplasmin it is deficient due to the genetic deficiency, okay. So plasma concentration of free copper is high. So this copper it gets deposited in liver, in substantia nigra in the brain, basal ganglia, and also causes local degeneration. So lifelong therapy is needed in these cases because it is in the genes. So this problem is not going to go away. So lifelong penicillamine, it is given to prevent progression of the disease. So for this purpose, its dose is 0.5 to 1 gram 1 hour before or 2 hours after the meals. Potassium sulfide is may be given with each meal to decrease the absorption of dietary copper. And other uses include copper and mercury poisoning, chronic lead poisoning, cystinuria and cystine stones, and scleroderma. In scleroderma, it benefits by increasing the soluble collagen. So the stiffness that is seen in scleroderma, it can decrease. Okay. So let's discuss each of these in detail. For copper or mercury poisoning, It is given for few days in the dose of 1 to 1.5 gram per day. So this is a drug of choice in copper poisoning. And it is also alternative drug to dimercaprol or succimer for mercury poisoning. So the mercury poisoning can happen due to thermometer, breaking in the mouth. Chronic lead poisoning, it may be used as an adjuvant to calcium sodium aditate, but succimer it is preferred. In cystinuria and cystine stones, it promotes the excretion of cystine and prevents its precipitation in the urinary tract because penicillamine cystine complex is more soluble than dicystine. It was also used as a disease modifying agent in rheumatoid arthritis, but now we have other agents available. Its side effects: short-term administration of penicillamine does not cause much of a problem. Okay. Various cutaneous reactions, itching, and febrile episodes may occur. However, long-term use it produces more toxicity, skin problems, kidney problems, blood collagen tissue toxicities. They can be seen during prolonged treatment. Desferrioxamine. Ferrioxamine, it is a long chain iron containing complex which is obtained from an actinomycete. Chemical removal of iron from it yields desferrioxamine, which has very high affinity for iron. 1 gram is capable of chelating 85 milligram of elemental iron. The straight chain desferrioxamine molecule binds round ferric iron and forms a stable non-toxic complex which is excreted in urine. Desferrioxamine removes loosely bound iron as well as that from hemosiderin and ferritin, but not from hemoglobin or cytochrome. Another desirable property is its low affinity for calcium. Only some part of orally administered desferrioxamine it is absorbed into the system. And if we administer desferrioxamine parenterally, it is partly metabolized and rapidly excreted in the urine. Its uses include acute iron poisoning. Mostly iron poisoning is seen in children when they accidentally ingest the iron tablets. Okay. So for this is the most important indication of desferrioxamine, which may be life-saving in these children. Transfusion cirrhosis, it is usually seen in people with conditions like thalassemia who receive repeated blood transfusions. So repeated blood transfusions may result in iron overload. So desferrioxamine, it is given in the dose of 0.5 to 1 gram per day intramuscularly. It helps in excreting the chronic iron overload. It can also be given IV concurrently with the blood transfusion, 2 gram per unit of blood. Its side effects: desferrioxamine, it can cause histamine release, resulting in fall in BP, flushing, itching, urticaria, and rashes. A variety of allergic reactions are reported. Changes in lens and retina can occur on repeated use. Other side effects are abdominal pain, loose motions, muscle cramps, fever, and dysuria. Okay, daferriprone. This is an orally active iron chelator which has simplified the treatment of transfusion cirrhosis in the thalassemia patients. So, since desferrioxamine it is given IV or IM, but deferriprone it is given orally. It is an orally active iron chelator. Okay, so excessive hemolysis occurs in these patients and they have to be given repeated blood transfusions. An iron chelator has to be used to clear the resulting iron overload. Oral deferriprone is a somewhat less effective alternative to injected desferrioxamine, but side effects and cost of treatment are reduced. Deferriprone may also be used for acute iron poisoning, but is less effective than desferrioxamine. Facilitating removal of iron load in hepatic cirrhosis is another indication. Its side effects include anorexia, vomiting, altered taste, joint pain, reversible neutropenia, and rarely agranulocytosis. Deferrasirox. Deferrasirox, it is another oral iron chelator which lowers serum ferritin and hepatic iron concentration in patients with chronic iron overload due to repeated blood transfusion. So it is also used in non-transfusion dependent thalassemia syndromes. Deferrasirox, it has high affinity for iron but low affinity for other trace metals like copper and zinc. It is absorbed orally and needs once daily dosing. It is excreted in bile. Side effects are nausea, epigastric pain, headache, pruritus, rashes, and skin discoloration. Infrequently, gastrointestinal ulceration and hemorrhages, proteinuria, and renal failure are also reported. Thanks for joining in today.